Hello, everyone, and good evening. I want to thank you so much for joining us for our latest clinical education webinar, Actinic Keratosis, Advances in the Management of Field Cancerization. The webinar will discuss the concept of field cancerization, the pathophysiology of actinic keratosis development, and emerging new therapies in AK treatment and their mechanisms of action. My name is Kim Montanarello from VisualDx, and before I introduce our presenter, I do have a few housekeeping notes. This webinar is being recorded and will be shared to all the registrants. We encourage questions from the audience, so please submit your questions in the Q&A box. And while you're muted, we will try to get to as many questions as we can once the lecture is complete. Following the clinical presentation, we're going to test your skills with a Kahoot quiz, which I'll put in the chat. It will award a prize to the winner, so you want to have that app downloaded. It's free, and we've had a lot of success with that in the past webinars. We also ask that you take our survey at the end to provide feedback, and my colleague Mike Venanzi will provide a demo of VisualDx at the end for those interested in staying on. Now I'd like to present our presenter for the evening, Dr. Christopher Bunick. Dr. Bunick is an Associate Professor of Dermatology at the Yale School of Medicine, specializing in general medical dermatology and dermatologic surgery. He also conducts research on the three-dimensional protein structures that form the skin's barrier. He sees patients at Yale Dermatology Associates and provides care of patients with all dermatologic conditions. Dr. Bunick.
Thank you very much. Can everyone see the presentation correctly?
Yes, I can see it.
All right, thank you, Kim. So it's very exciting for me to be able to talk to you today about actinic keratosis, and particularly touch on the advances in the management of field cancerization, and we'll define more of what that means. Let me first reveal my conflicts of interest. Just disclosures, I am currently an investigator as well for Almirall, as well as a consultant and speaker. I've also served as a consultant and speaker for a couple other companies, including Allergan, UCB, and Sanofi Regeneron. In dermatology, the sun is really a key part of what we do, what we manage, and our practice revolves around the sun and how it impacts the human skin. And we're going to talk about this at length today. What we're looking at on the left is this fiery orange ball, the sun. And it turns out that on the top, I have listed here in white some positive effects that are attributed to the sun, such as improved mood, relieving of stress, treating seasonal depression, improving sleep, generating vitamin D, as well as the harnessing of UV for phototherapy and photophoresis, which we do in dermatology all the time. But there are also some negative effects of the sun, shown in yellow at the bottom. This can include eye damage, such as cataracts, retina damage, heat exhaustion and heat stroke, sunburn, solar urticaria, and polymorphous light eruption, abbreviated here PMLE. And then there's pre-malignant lesions, precancerous lesions called actinic keratosis, which are the subject of our discussion today, as well as skin cancers and wrinkles in aging, which nobody likes. On the right, I show the sun and a portion of the electromagnetic spectrum. If we start on the right with visible light and move left, we come to UVA, which is the longest wavelength, lower energy UV component, the UVA. If we move one to the left, we have UVB, and then one more to the left, we have UVC, which is the shorter wavelength, higher energy UVC, or UV rays. And these UVC rays are actually filtered out by the ozone layer. So it's UVA and UVB rays that are reaching the skin, with the longer wavelength, shorter energy UVA rays penetrating deeper into the skin. And these sun rays that reach the skin cause pre-malignant lesions called actinic keratoses that are one of the most common skin conditions that we face in dermatology. They're characterized by these dry, scaly papules on the skin, and they're one of the most common reasons for dermatology visits. In fact, some studies say that up to 10% of the patients that we see have actinic keratoses, accounting for maybe up to 5 million visits per year. And on the right, you can see the prevalence can be upwards of 60 million Americans that have actinic keratoses for a cost burden on society of over $1 billion per year. So if untreated, these actinic keratoses progress to squamous cell carcinoma. And here towards the bottom in gray, I show this progression from the photodamage caused by the sun to these pre-malignant actinic keratoses to in situ squamous cell carcinoma, also called Bowen's disease, and then finally progression to invasive squamous cell carcinoma. And there's a number of numbers out there depending on which study you look at, but in general, the rate at which the actinic keratoses progress to squamous cell carcinoma is thought to be anywhere from 0.025% to 16% per lesion per year. We constantly in dermatology advise our patients to wear sunscreen, hats, sun protective clothing to try to intervene at this photodamage stage. But from a therapeutic standpoint, one of the most common points that we try to intervene in the clinic is at the actinic keratosis stage, because we want to prevent progression to in situ or invasive squamous cell carcinoma. So let's take a look at what actinic keratoses look like. So here's just a few clinical images to familiarize people with what they look like. In the upper left, we see a reddish brown scaly papule on the left temple. In the upper right here, we see a pink papule with more hyperkeratotic white scale overlying on the dorsal hand. In the bottom left, there's an even more hyperkeratotic pink papule. And then in the bottom right, I show an image of these pink-brown actinic keratoses, because I want to emphasize the point that actinic keratoses can be pigmented and have a brown color, just like sometimes we have pigmented basal cell carcinomas. You can also have pigmented actinic keratoses, and I think that's an important clinical point to understand. And on the far right in this black box is just simply the distribution, the sun-exposed distribution of actinic keratoses involving largely the head, the neck, extensor upper extremities, and extensor lower extremities. Actinic keratoses can be divided into 3 different grades, grade 1, 2, and 3. If we start at the left at grade 1, actinic keratoses that are grade 1 are felt better than seen. They're slightly palpable, hardly visible, and histologically, they have a little bit of atypia histologically. Grade 2 actinic keratoses are a little bit thicker, so they're more easily felt, and because they're thicker, they're more easily seen, and this is reflected in a slightly more histologic just keratosis. And then on the far right is the grade 3 actinic keratosis, where they're much thicker and more hyperkeratotic. They're very obvious both by feel and by sight, and this is reflected in a more robust pathology. The key point is not necessarily the grades. I don't document in my chart what grade of an AK I think a patient has. But what's important is that it doesn't matter what grade an actinic keratosis might be, it can still progress to squamous cell carcinoma. And I think that's the key message to remember. So let's take a look at some natural history of actinic keratoses. And this is data based on a VA-based clinical trial where approximately 7,800 facial actinic keratoses were followed in about 170 patients over an average period of 3.5 years. They found in the study at year 1 that about 55% of the actinic keratoses had spontaneously resolved, but a third of those, importantly, recurred by year 3. And the key meaning of that is that it's not okay to just simply tell patients, oh, they're going to resolve on their own. The majority, 55%, might resolve on their own. No, these lesions need to be treated clinically because there is a high degree of recurrence. And it turns out in this particular study that 65% of in situ or invasive squamous cell carcinomas arose in a previously noted actinic keratosis, making actinic keratoses an important intervention point, as I showed earlier. If we look at the graph on the right, on the y-axis, we're looking at the risk of progression of actinic keratosis to any keratinocyte carcinoma. So that's basal cell or squamous cell. And we can see that it's divided into a couple other subcategories here. And this is over a course of 5 years. If we focus, for example, just at year 4, and we go up to the solid black circles, which is invasive or in situ SCC, we can see that the risk of a actinic keratosis at 4 years progressing to invasive or in situ SCC is around 2.75%. So taking all this data together, there's a couple numbers that this study put out, and that is that the rate of progression to SCC is around 0.6% per year per lesion, and the progression to any keratinocyte carcinoma is around 1.1% per year per lesion. And when you have multiple lesions on the body, that is a cumulative risk for a development of a lesion into skin cancer. So how are individual actinic keratoses managed? You have a patient maybe with 1 or 2 actinic keratoses. Well, the predominant method that's used in dermatology today is cryotherapy. Cryotherapy involves cycles of freezing and thawing, and it leads to destructive effects, both that are immediate and delayed. So the immediate mechanism of actions is thought to be the direct damage from the freeze-thaw cycles. The delayed mechanism of action is actually thought to be a progressive failure of the microcirculation. In the bottom right, I show some data from the National Inventory Medical Care Survey, which looked at the number of visits for actinic keratosis where cryotherapy was actually used. And this is from 2009 to 2016. Clearly in 2016, there's an outlier of almost 10 million treatments of cryotherapy for AKs, but the average it seems to be around 3 to 4 million visits per year where cryotherapy is the mainstay treatment of individual actinic keratoses. So let's take a deeper dive into the mechanism of action of cryotherapy, just because it is such a commonly used procedure that it's important we understand the mechanism of action. And there's 4 key points I want people to take away, and that is they're denoted A, B, C, and D. So we'll start in the upper left at A, and that is that ice crystals can form within the cells when you have sufficiently low temperature from the cryotherapy. So these ice crystals can lead to direct injury to the cell, and they also cause water shifts, both out into the extracellular space where there's also ice damage, and then water that goes back into the cell, causing swelling and rupture of membranes. And if we go down to B, this ice crystals can also cause vascular injury, leading to platelet aggregation, microthrombosis, and ischemia, and vessel vasoconstriction, ultimately leading to failure of the microcirculation, vascular congestion, vessel obliteration. In C, cell death can also occur via apoptosis. In the bottom, there's an interesting phenomenon called cryoimmunological response. It's thought that destruction of malignant cells can lead to some neoantigens on these dead malignant cells that then can elicit a host immune response to the malignant cells. And that's kind of indicated here at the bottom by the necrosis pathway, where you see some neoantigens produced from the malignant cells that activate T cells and lead to T cell proliferation. But cryotherapy itself comes with some significant side effects, as do many of the current therapies for treating actinic keratoses. These include dermatitis, itching, pain, redness, swelling, and scarring. And here on the bottom left is an image of some significant redness and swelling from cryotherapy. A lot of these side effects can lead to patients not wanting treatment for further actinic keratoses or treatment non-compliance if they're using certain topical field therapies, which we'll discuss more of. And this particular data on the right from a British Journal of Dermatology study suggested that if you're using cryotherapy within a field of actinic keratoses, that there's a very low sustained clearance rate, possibly around only 4%, suggesting that cryotherapy is not necessarily very good at treating actinic keratoses within a larger field of damage. And that's a key point we're going to focus on. So here I'm illustrating that point, and that is that UV photodamage is more than meets the eye. So if we look on the left, we see a patient where there's some lentiginous on the forehead, some lentiginous on the bilateral cheeks and nose. Overall, it looks like a pretty healthy patient with some sun exposure and a few obvious lentiginous and melanin accumulations on the face. But if you examine the patient with special UV light, particularly in this case, a Canfield camera, we see that there are numerous melanin accumulations across the face. And each of these melanin accumulations in this particular image is highlighted with a yellow line around it. And so there's much more photodamage than what we can see clinically. Our naked eye can only appreciate so much. And with all this different photodamage, it's important for us as dermatologists to understand how to tackle the damage, the subclinical skin damage that we can't see. So to understand more about what's happening with this photodamage, here are a couple studies that will actually indicate that this photodamage contains UV mutant clones. So in the top study, mutant P53 cells were identified by antibody staining, and they were found to form clusters, these clone clusters. And on the right, this is shown in brown in the histologic image. And this study found that the number of these P53 clusters correlated with skin cancer risk. In the bottom study from Science in 2015, these authors did DNA sequencing of normal eyelid skin, and they found that up to 32% of the skin cells had carcinogenic mutations. And the level or the burden of these mutations was comparable to breast cancer. So this photodamaged skin that's subclinical is actually a sun-exposed patchwork of thousands of evolving clones. And that's kind of what's illustrated here on the right in this colorful, kind of like, looks like colorful bubbles. And we see these genes at the top. So P53 and some notch genes are critical players in this. But think of photodamaged skin as a patchwork of thousands of evolving clones. This is a recent study published this year in Science Advances 2021. One of the co-authors was Dr. Sean Christensen, which is he's one of my colleagues here at Yale. And another author was the late Oscar Colegio, a great transplant dermatologist who suddenly passed away. These authors, as well as their colleagues, identified that UV mutant clones correlate with skin cancer risk. So what they did is they took 1 to 2 millimeter biopsies from normal skin adjacent to skin cancer. And if we go down to the red box in the bottom left, the skin was from patients that had varying degrees of UV damage and varying skin cancer burden. And if we go to the data on the bottom right, what we're seeing on the y-axis is UV signature mutations in different samples. And these samples include normal skin from patients that had multiple squamous cell carcinomas. And in blue, UV signature mutations in normal skin from patients that had only one SCC. And the data was statistically significant, meaning that the normal skin of patients with more history of SCCs had a higher UV signature mutation burden. And both of those were compared to SCC tumors themselves, which was also statistically significantly, these SCC tumors had more UV signature mutations than either of the normal skin situations, suggesting that UV mutant clone burden absolutely correlates with skin cancer risk. So the UV signature mutations in subclinical photodamaged skin are critical to pathogenesis of future skin cancers. So this leads to the concept that's sort of the center point of our topic, our conversation today, and that is field cancerization. And this is the article from 1953 that first defined or proposed field cancerization. These authors did a review of 783 cases of oral squamous cell carcinoma of the lip, oral cavity, and pharynx. Grossly, about 11% of the cases had multiple primary lesions. But in all cases, the clinically benign mucosa adjacent to the cancer themselves was also microscopically abnormal, including dyskeratosis or separate islands of SCC in situ or an invasive squamous cell carcinoma. So this led the authors to propose the concept of field cancerization with a definition something like this: an area of epithelium that's altered by regional carcinogenic effect. And this can lead to irreversible changes that eventually manifest in cancer. So let's take a closer look at how field cancerization can be applied to actinic keratosis. So if we redefine it in terms of actinic keratosis, we can think of field cancerization as the anatomical area, including or adjacent to AKs, that has visibly photodamaged skin and is characterized by pigmentary changes, rough texture, atrophy, or telangiectasias. and it's prone to development of cancers. So if we look at the schematic here, we start on the left with the sun. So chronic exposure to UV or other carcinogens can cause irreversible genetic changes, such as the blue, purple, or green mutated keratinocytes. If we move over one to the right, these blue, purple, and green mutated keratinocytes can undergo clonal expansion, leading to multiple dysplastic fields. And if we move one more to the right, in this case, the purple dysplastic clone or field develops into a visible actinic keratosis, but you still have subclinical dysplastic fields of the blue and the green keratinocytes. And then on the far right, this AK has now transformed into an invasive squamous cell carcinoma, and you still have these subclinical dysplastic fields in the blue and the green. So this ultimately is part of what's known as a multi-step tumorigenesis pathway. So that, again, the idea on the left is ultraviolet light, in this case UVB, can cause signature mutations like cyclobutane pyrimidine dimers or 6,4 photoproducts, which are usually dealt with by DNA repair mechanisms like nucleotide excision repair. But in some cases, you get a mutated cell shown in the center top in red, and this can expand to a clone. And then this can lead to multiple clones in a mutated field, like such as shown here on the dorsal hand. And then histologically or clinically, we see the progression to an actinic keratosis and then to a squamous cell carcinoma. And this multi-step tumorigenesis actually satisfies two hypotheses, meaning that the burden of precursor lesions does in fact determine the risk of carcinoma. And the treatment of precursor lesions does in fact decrease the incidence of carcinoma. So how do we bring this to an everyday problem that we face in the clinic with our patients? So bringing field cancerization into our clinic patients. So what we see on the left is a patient with multiple squamous cell carcinomas in a field of actinic keratoses on the scalp. And on the right, this is a patient that had one squamous cell carcinoma in situ and multiple actinic keratoses. And these actinic keratoses pose a significant risk of development of subsequent cancer. So what is it that actually drives this risk of cancer or this progression to cutaneous SCC? So let's take a minute to talk about the genetic drivers of cutaneous SCC. Genome-wide sequencing has identified that over 85% of the mutations are UV signature mutations. And I cite here 4 different studies that looked at the gene mutation frequencies occurring in SCC tumors. And 3 key genes that I want you to take away are P53, Notch1, and Notch2. So P53 is known as the guardian of the genome, and it encodes for an important, very important tumor suppressor protein in the body. But in actinic keratoses, as many or more than 60% of actinic keratoses can actually harbor P53 mutations. So on the next couple of slides, let's take a little closer look at P53 itself so we understand what's happening. So this is a schematic of P53, just looking at the domain organization and where certain mutations in cancer actually occur. So if we start at the left, at the N-terminus of this 393 amino acid protein, we see at the N-terminus, there's this red transactivation domain, followed by a yellow proline-rich region. Then we have this central pink DNA binding domain. And if you look at all these black bars overlying the central DNA binding domain, that's characterizing the mutation frequency at that particular amino acid. So the majority of mutations in P53 that lead to human cancer occur in this central DNA binding domain. And then towards the C-terminus, there's a tetramerization domain in green. And then lastly, in blue, a negative regulatory domain. And I'd like you to focus on or remember residues 245 and 248, because we're going to look at them a little bit closer on the next slide. So before you get scared of structural biology, I will walk you through these images. So on the left, we're looking at the X-ray crystal structure of P53, particularly the DNA binding domain. And what we're looking at are L1, loop 2, and loop 3. And here in this gray stick at the very top is the DNA. And on the right, we're going to zoom in and focus on 2 residues, the glycine 245 and the arginine 248. I point to them with the blue arrows. So if we look at glycine 245, it forms hydrogen bonds indicated by these green dashed lines to an arginine 249, which itself is forming a salt bridge to glutamate 171. So mutation of glycine 245 is going to disrupt the stability of p53 central DNA binding domain. The arginine 248, on the other hand, is actually participating in binding interactions with the DNA itself. And so mutation of that residue may cause consequences for DNA binding. Both glycine 245 and arginine 248 are highly mutated in cutaneous squamous cell carcinoma and actinic keratoses. So this brings us, so we've talked a little bit about the science. Let's bring it back into the clinic and talk about how we're going to use field therapy to treat field cancerization. So what are the treatment options for a patient that has numerous actinic keratoses in one body area? So in the upper left, I show a patient with actinic keratoses on the forehead. In the center here, there's actinic keratoses on the scalp. And on the right, a patient with multiple actinic keratoses on the extensor forearms and dorsal hands. So prior to 2020, there were a number of field therapy options to try to tackle numerous actinic keratoses like this. So 4 of the key or most used field therapy options are listed here. 5-fluorouracil at the top is a topical chemotherapy. It's usually applied anywhere from twice daily for 2 to 6 weeks, depending on the formulation. There's several formulations out there, but it's known to cause a lot of skin redness and swelling, affect patient quality of life, and sometimes impact whether they can go to work or social events. Similarly, a imiquimod cream is used topically to treat fields of actinic keratoses. It's a topical immunomodulator targeting toll-like receptor 7, and it's thought to help boost the body's immune response to get rid of diseased or malignant skin cells. It's generally applied anywhere from 4 to 16 weeks, and it can cause skin to redden and swell, similar to the 5-fluorouracil. The third down is Ingenol mebutate. This is a plant-derived gel that induces cell death in treating actinic keratoses, also causing redness swelling. The benefit or the nice aspect of Ingenol mebutate was the fact that it was able to be applied, depending on the location, for either 2 or 3 consecutive days. So it was a short duration of treatment, and that was very convenient for patient compliance. But we'll come back to Ingenol mebutate in a second because it's no longer available. Lastly, I'll talk about a procedural field therapy, photodynamic therapy. It uses oxygen and photosensitizing agents like aminolevulinic acid with blue light to cause a photochemical reaction that destroys actinic keratoses. ALA is metabolized in the cytoplasm, leading to elevated protoporphyrin 9 in mitochondria. And it's actually these protoporphyrin 9 molecules that absorb the light and then transfers that light energy to oxygen, producing singlet oxygen that causes damage within the cell. There's also another topical treatment, diclofenac, which is a non-steroidal anti-inflammatory that can target COX-2. It's generally less used than these agents and typically requires quite a long treatment time. And so we won't focus on that anymore extensively. Ingenol mebutate, I'll just make a simple disclaimer because we won't talk about that anymore because it's been withdrawn from the market in the US, Europe, and Canada because it was found to potentially cause an increase in skin tumors. And so this is no longer available. So this brings us to understanding more about what are patients' needs when it comes to field therapy. Well, I can tell you it revolves around dealing with the complications of the current field therapy options. So there are many side effects of topical treatment of actinic keratoses, including dermatitis, itching, pain, redness, swelling, scarring. And as mentioned before, they all can lead to treatment non-compliance. So if we look at this gentleman on the left who had 5-FU therapy, we see the degree of redness all over the face. On the right, we follow a woman from day 3 all the way to day 23. And look at the degree of redness and swelling on the face at day 23. And I think that this progression really speaks to the fact that some topical therapies for actinic keratoses can have a prolonged patient discomfort, a prolonged impact on their ability to perform daily activities, whether it's go to work, hang out with family, go to social engagements. And I think this is an important aspect of treatment of actinic keratoses that we have to understand in dermatology. So since we showed some 5-FU data, I just want to briefly touch about this concept of combining 5-FU with calcipotriene. And I wanted to point out that it's not currently FDA approved for actinic keratosis, and it's based on a small study where it was thought that the calcipotriene could lead to a shorter duration treatment, so twice a day for 5 days, when the two are used in combination rather than the 5-FU monotherapy alone. But the complete clearance rate of this combination on the face was only 27%. There was no significant difference in clearance on the scalp. It does require the combination of two prescriptions, and there are still local skin reactions that occur. And so I think it's important to understand that combining calcipotriene is not a holy grail for field therapy in actinic keratoses. So this brings us back to the quality of life issue that I was discussing, and that is that there's a real need for effective, well-tolerated, short-duration topical treatments for actinic keratoses. This is a systematic review that just was published in 2021 that looked at patients' perspectives of topical field-directed treatments for AKs. And if you look at the bottom underlying statement in this abstract, they found that treatment adherence and patient satisfaction were much better with shorter duration treatment regimens. Seems to make sense. These are current 2021 clinical management recommendations. And these authors, down here in the conclusion, highlighted in yellow, recommend or call for dermatologists to understand that the value of shorter course therapies and their positive impact on patient adherence to their treatment regimen. So this leads to the advance, or what's new in field therapy treatment for actinic keratoses in 2021 and beyond. And that is a new ointment, Tirbanibulin, for actinic keratosis. And what I want to do over the remaining slides is walk you through the phase 3 trials of Tirbanibulin that were published recently in the New England Journal of Medicine. So Tirbanibulin has a dual mechanism of action. It's both a tubulin polymerization inhibitor as well as an SRC kinase inhibitor. And SRC kinases are non-receptor tyrosine kinases, important in cell proliferation, growth, division, et cetera, and differentiation. And tubulin is involved in cytoskeleton. So let's take a closer look at this mechanism of action. So if we're going to think about microtubules, the first thing we need to understand is, well, what are the key components of the cytoskeleton? And that's what I'm illustrating here. So here's a schematic of an epithelial cell, and I'm depicting the 3 key filament systems of this cytoskeleton. In red, we have actin microfilaments. In blue, intermediate filaments, such as keratins are an intermediate filament. And then we have microtubules in this green or teal, depending on how it's coming through on your screen. And these microtubules are very important for a number of functions, and we're going to talk about them here. So on the left in the yellow box, what do microtubules do? Well, they help form cell structure because they are part of the cytoskeleton and they provide structural integrity to the cell. Cell transport. So it turns out a lot of materials within cells are carried by motor proteins that move along the surface of the microtubule. So it's very important for cell transport within the cell. And lastly, microtubules are very important for cell division. You know, if you remember back to the early biology days when we were in grade school, we learned that very early on that microtubules help segregate, or they're responsible for directing where chromosomes go when genetic material is divided. On the right is a schematic of how microtubules grow and polymerize or depolymerize. So if we look at panel A on the left first, let's kind of walk through this. So we have beta tubulin and alpha tubulin shown in purple and blue respectively. So the dimer of tubulins, the alpha and beta tubulin dimer, is generally bound to GTP, and it needs to be bound to GTP to assemble or polymerize at the positive end or growing end of the microtubule. After the GTP-bound tubulin dimer binds, the GTP is hydrolyzed to GDP, and then down at the negative end of the microtubule, it's all tubulin dimers bound to GTP, but you need the GDP, excuse me, the GTP bound form is what's binding at that growing end. And if we look over at the right, what we see is that microtubules are very dynamic. That this is representing, you have polymerization and depolymerization. And that's the main concept I want you to take away, is that they're dynamic, growing and retreating. And Tirbanibulin is an inhibitor of this tubulin polymerization. So it's thought that the Tirbanibulin binds the beta tubulin and helps inhibit tubulin polymerization, so you don't get the growth of the microtubules. This leads to disruption of the spindle microtubule formation in the proliferating cells, like the proliferating actinic keratosis, keratinocytes, and this leads to cell death by apoptosis. So let's take a closer look at how this Tirbanibulin functioned in clinical studies. I list here a number of the clinical studies that Tirbanibulin was exposed to or put through, including a couple phase 1, a phase 2 trial, 2 phase 3 trials, which are what we're going to focus on today, and safety studies. So what we're looking at here are the 2 phase 3, identical phase 3 trials that Tirbanibulin went through and was published in this New England Journal of Medicine article. There's approximately 350 subjects per trial, and this trial was double-blind, vehicle-controlled, randomized. Patients received either Tirbanibulin or vehicle, and they applied it once daily for 5 days in an area of approximately 25 centimeters squared that contained about 4 to 8 actinic keratoses lesions. Patients had to be 18 years or older, and they had to have typical, visible, discrete actinic keratoses. And after this 5-day of treatment with either the Tirbanibulin or the vehicle, they were looked at for a primary efficacy endpoint of complete clearance at day 57, or a secondary endpoint of over 75% partial clearance of lesions at day 57. Those patients that achieved complete clearance at day 57 were further followed in a 1-year follow-up phase to look for evidence of recurrences. Patients that were excluded from this trial were anyone that had atypical, hypertrophic, recalcitrant, or rapidly changing AKs, or open wounds or suspected skin cancers next to the or within the treatment field. And then sunscreen use was prohibited from day 0 to 57. So let's take a look at the patient demographics. So we see on the left the characteristic, then we see trial 1 and trial 2 in the center and on the right. The average age across both trials was around 70 years of age. About 85% or so of the patients were male, and about 99% were Caucasian with either Fitzpatrick 1 or 2 type skin. The average actinic keratosis count was around 6 in the treatment area across the entire study. And about 45% or so of the patients involved in the trial had a previous history of skin cancer. So let's look at some of the results. So about 700 patients with actinic keratoses on the face or the scalp participated and received either the Tirbanibulin ointment or the vehicle ointment. And if we look first at complete clearance of lesions within the application area at day 57, approximately 49% of the patients that received the Tirbanibulin 1% ointment had complete clearance, compared to only 9% of those that received the vehicle. And if we look at the patients that had partial clearance of lesions within application area, day 57, 72% of the Tirbanibulin treatment group has partial clearance at day 57, compared to only 18% with the vehicle ointment, indicating that Tirbanibulin ointment was in fact superior to placebo at 2 months in this trial. For those patients that had complete clearance and then were followed for up to a year, about 47% had an AK lesion recurrence within the field of treatment at 1 year, suggesting that actinic keratoses are a chronic problem, not a discrete problem, but a chronic problem for patients that have significant UV photodamage. Here's a different way of looking at that data. This is the pooled efficacy data from these phase 3 trials I was just showing. Complete clearance is here on the left, partial clearance on the right. The y-axis is the percent of patients, and in the dark blue bars are the Tirbanibulin treated group, and then in the hatched grayish bars, the vehicle, showing that the treated Tirbanibulin group was statistically significant for both the complete and partial clearance. A different way of looking at this data is to look at the change in number of AK lesions from baseline to day 57, and that's what I show here. If we look on the top, there's trial 1 on the left, trial 2 on the right. The dark magenta line is the Tirbanibulin ointment treated group from baseline all the way to day 57. And the light pink is the vehicle. And what we see with the Tirbanibulin treated group is that the number of AK lesions trends or decreases at each time point, each visit time point, all the way down to day 57. The trend is decreasing number of AK lesions. And this is also what occurs in the trial 2 on the right. And if we look at the hard data on the bottom, if we look just at the mean percentage reduction of number of AKs from baseline to day 57, in the Tirbanibulin groups, it's somewhere around 78 to 80% mean reduction. So one of the most important things that we as dermatologists need to understand is, does this new available topical field therapy for AKs and treating of field cancerization, how does it improve, or does it improve the quality of life of our patients? What are the reactions, the skin reactions that this new medication causes? So in order to assess that, the trial authors looked at 6 different local skin reactions: erythema, flaking or scaling, crusting, swelling, fasciculation or pustulation, and erosion or ulceration. So those 6. And they graded each of these 6 on a 4-point scale, with 0 being absent, then mild, moderate, and severe. So the maximum score that a patient could have is all 6 of these were severe would be an 18. So your range of scores from 0 to 18 total. If we look at trial 1 and trial 2 on the bottom, the dark pink or magenta is the Tirbanibulin treated group. And we see in both trials that the peak of the mean composite local skin reaction, the peak of the local skin reaction is around day 8. And then by the 2nd week, it's diminishing. And if we look at that total score at day 8, it's around 4, right? It's around 4 out of the possible 18. So you're looking at a significant, only a small percentage of the total amount of severity of skin reaction possible was actually occurring in these patients. And I think that that is a very important concept to be able to discuss with patients that are thinking about using this medication, is that there seems to be a peak around day 8 of some of the skin reactions, but it diminishes by that 2nd week. So let's take a clinical look at what happens in these scenarios. So what we're looking at here is a 75-year-old white male scalp who, this is day 1 baseline. If we go to day 8, we can see that there was some moderate erythema and moderate flaking. And by day 15, we see that that's diminishing, and that continues to diminish throughout day 57 with the clearance of the AKs. Here's a 56-year-old white female, and we can see around day 8, again, a combination of moderate erythema, moderate flaking, and mild crusting, which is improving by day 15. And as the patient continues to improve, we see the clearance of the AKs and a reduction in these local skin reactions. Here's a 69-year-old white male looking around the right temple area, who on day 8 had some severe erythema, flaking, moderate crusting, and mild swelling. Again, this is showing some improvement at day 15 and a nice clearance of the AKs and reduction in these skin reactions, certainly by day 57. And lastly, this is a 65-year-old white male, a number of actinic keratoses here on the scalp, nicely highlighted in red. And we can see at day 8 and day 15 that this gentleman, in fact, had some severe flaking and moderate erythema, but that this area by day 29 and 57 is reduced in terms of the flaking and erythema, and the actinic keratoses seem to be resolved. So that was a special way of looking at the localized skin reactions that were reported in this New England Journal of Medicine article. But what about other adverse events? So there were, in general, no serious adverse events directly attributable to the Tirbanibulin, although there was one patient that that died of suicide unrelated to the medicine, and a myocardial infarction, which was deemed to be unrelated to the medicine. There was around 6 to 7% of application site pain or pruritus, and a 2 to 3% risk of viral upper respiratory tract infection that was observed. That seems to be a commonplace side effect in pretty much every medicine. Importantly, however, there was no phototoxicity, no contact sensitization, and no photoallergic reactions observed for Tirbanibulin in this particular New England Journal of Medicine article study. So in summary, what we've discussed is that there is a new player in the topical field therapy for actinic keratoses. It's called Tirbanibulin. It works by a unique mechanism of action, at least among AK medicines, as a microtubule inhibitor. But we know that microtubule inhibitors have been used for quite a long time in solid organ cancers, right? But in this case, it's packaged uniquely in this Tirbanibulin ointment. You can see here these kind of old antibiotic-like plastic sachets here that contain the medicine. And importantly, as we talked about quality of life of our patients, it can be used once daily for 5 days. And so it's a short duration, highly effective therapy. So it's convenient for the patient, but also has the efficacy that we're looking for as dermatologists. And I wanted to end our discussion today by highlighting this paper by Dr. Barbara Gilchrist. So she just published in the Journal of Investigative Dermatology in the last month or so an article asking a provocative question, and that is, given what we know about the biology of field cancerization, which I just described to you today, is it still okay that we use AK selective therapy? Or should we be using field therapy? And I've highlighted in green this argument. And it article itself argues that field therapy, rather than AK selective therapy, is the more logical approach to cancer prevention. And I think that if you think about the science and the clinical data that we talked about today, that I actually agree with Dr. Gilchrist that field therapy logically makes sense. And to help explain this, she has this very interesting diagram, which I show on the right. So we're going to walk through this. So if we look at that y-axis first, we start at the bottom of the y-axis where you have normal skin, and then you have photodamage, and then actinic keratoses, and then SCCs and AKs. This is the severity of field cancerization, or that progression of photodamage to squamous cell carcinoma. And we're following it over patient age or cumulative UV damage. And this dark blue line represents the progression of UV damage with increasing patient age. And so what we normally do or have been doing in dermatology to a certain, from most people, most practitioners, including myself, is that the first field therapy is when we see actinic keratoses. And so yes, if we treat patients with field therapy that have actinic keratoses, this red represents an improved or decreased severity of UV damage after that field treatment. But after a period of time, that damage resumes. That's the upward part of this red line. And in the dashed blue lines, Dr. Gilchrist shows that if you improve your sun protection practices, sunscreen, hats, sun protective clothing, you can further modify this progression and decrease it a little bit more. But what she argues in this article is that why are we as dermatologists not starting our field therapies when we see photodamage? I showed you the image with the UV light of the amount of photodamage that's subclinical. And so Dr. Gilchrist is arguing, start your first therapy here at photodamage. You see the decrease in red of this UV damage. Yes, it does resume again, but if you do sun protective practices and then repeat a field therapy later in life, shown here by RX2, you then get now this purple dotted line, which is, again, another slowing of that progression of the field cancerization effect to squamous cell carcinoma. And so with that thought, I thank you for your attention, and thank you.
Well, thank you so much, Dr. Bunick, and we appreciate everyone staying with us for this past hour. If we have any questions, be sure to use the Q&A box. We're going to use the Kahoot in just a couple minutes. So if anyone has questions, in the meantime, please come through. One question that came through that I'm not sure if you're going to be able to answer, but they want to know why sunscreen was prohibited in the study. Do you happen to know the answer to that?
And specifically to the study, I don't know why the sunscreen was prohibited, but just from a practical standpoint, it seems to it could be a confounding factor, just to make sure that to know that Tirbanibulin, that you're looking only at that one effect. If there's some other agent being applied, it really does diminish the potential for any confounders, I think, in the study.
Okay. Well, I think on that note, we're going to begin the Kahoot quiz. And again, I want to thank Dr. Bunick. I want to thank Almiral for sponsoring this webinar for today. I'm going to share my screen now so everyone can get going with Kahoot. We have can everyone see my screen at this point? Just making sure. You see a game pin of 7786745. It always works best if you have two devices, so on your phone and then also on a computer to play. We're going to give away a $100 Amazon gift card to the winner. Dr. Bunick was the one who put all the questions together and the answers for us, so we thank him for that. We'll just wait a few minutes while people get signed on. Again, the game pin is at the top. And always remember, if you can't stand for Kahoot or you can't stand for my colleague Mike Venanzi at the end who's going to give a demo, there is a survey at the end where we hope you take it, give us feedback, especially other topics that you might be interested in. We've been really happy and proud to be able to present educational webinars in full force, both in 2020, 2021, and beyond. We know it's important to our customer base and to people who just want to know about VisualDx. So again, thank you for joining us on this Tuesday evening if you're on the East Coast, or other times if you're other parts of the country. So hopefully there'll be more than two people that'll play tonight. Otherwise, it's going to be a 50-50 chance to win. So again, you can also use the desktop if you don't have the app. It's kahoot.it, and then enter the game pin 7786745. And when the Kahoot is over, I will turn it over to my colleague, Mike Venanzi, who will just give a quick demonstration of VisualDx. Oh, there we go. Okay, good. More people are joining. I think there's an issue with my internet at the moment, but yeah, he'll give a quick demonstration of VisualDx for anyone interested. And again, we're always happy to provide demos or speak to you further. VisualDx is used in over 2,300 hospitals, clinics worldwide, over half the medical schools in the U.S., including Yale. So it's an important tool both for education and practice. So on that note, I think we're going to get started because we're getting to be around 7:55. So everyone, good luck today, and thanks so much. Okay, I apologize if some of you had some technical difficulties. This never happened before us on the webinar, but I do want to congratulate in first place Jess. So Jess, I will be in touch with you and give you your Amazon gift card. So thanks everyone for playing. Again, apologies if some of you had a few technical difficulties with some of the answers. We'll try to get that worked out for the next time. So let me, I'm going to stop sharing my screen for just one moment. And before I hand it over to my colleague, I want to share one more screen with you, which is our next webinar. It's Skin Cancer 101, the cancer you can see. It'll be Tuesday, May 18th at 7 o'clock Eastern. You can register at visualdx.com/skincancer. Also, visualdx.com/events has all our events. I'll put that in the chat for everyone to see. And with that, I'm going to stop sharing my screen and pass it along to my colleague, Mike Venanzi. Thanks.
Thanks so much, Kim, and thanks so much, Dr. Bunick. Thanks so much for everyone for joining us for this last hour on actinic keratosis. I'm Mike Venanzi. I'm the Director of Business Development for the East Region. For the next couple minutes, I just want to demonstrate VisualDx. Many of you are active users of VisualDx. Some of you aren't, but perhaps for those that are users, you can learn something new. We've added some additional features to VisualDx, and I just want to walk you through some of that new functionality. So on the web that you're looking at right now is VisualDx. You can also use it on your mobile device, Android or Apple. You see all the same content, all the same images on your phone. Two approaches to VisualDx. You can look up any diagnosis. So if I want to look up actinic keratosis, for example, I'm going to go right to the page, and what you see is a quick synopsis, really written and intended to be used at the point of care, very concise and to the point. You have your billing codes, things to look for, diagnostic pearls. You have a nice differential diagnosis and pitfall section here with the hyperlinks. Best tests, how to manage it. You've got therapy options, and then also at the very bottom of the page, we have our drug reaction data along with our references. On the right-hand side of the page is our image collection, and VisualDx is world-renowned for our image collection, really focusing in on not just the common presentation of disease. You can also filter the images on the right-hand side to look for the skin pigmentation, as well as the body location. One other point I want to make is that we also have patient handouts written in a high school reading level. You can easily print that off, email it. It's also in Spanish. So just a nice time saver for clinicians to use VisualDx. The other approach to VisualDx is the forward-thinking approach where you're not quite sure what the diagnosis is, but you've got a chief complaint and you want to build off of that to ultimately create that differential. We've added a new feature on the center here where you can just select dermatology for skin of color. When I do that, I see a handful of chief complaints. So if I say it's a single skin lesion, I then can walk through and adjust the patient's age and gender at birth on the right-hand side, and then select the type of skin lesion. So what's great about this, you can actually get quick definitions of each of these skin lesion types. So if I say that the patient has a scaly plaque, and I can go on here and select the location. If I say it's on the face, specifically the forehead, any signs or symptoms, we'll say that it's a painful skin lesion and the appearance of the patient is well. Onset findings is chronic. You can also type in things at the top here. So if they have sun exposure, and then we want to view the differential. You can see how that differential looks. Right now you're looking at the common, which is considered first. And as you look at each of these diagnoses, they're in weighted format. So based on the findings that you've presented, you can see that actinic keratosis is coming up 7 of 7. As I scroll over, you'll start to see less and less findings. So for superficial basal cell carcinoma, you're looking at 6 of 7 with painful skin lesions crossed off. If I wanted to go right into the diagnosis for, let's say, cutaneous squamous cell carcinoma, I can view that full article just as I did with actinic keratosis before and get that quick synopsis, images. And then the final approach to VisualDx is looking at drug reaction data. So let's just say I've got a patient who's taking clindamycin. And they're complaining of abdominal pain, and I've got a 20 to 20-year-old male, and I want to see if there's any citations of clindamycin linking to abdominal pain. When I view the differential, it's automatically going to go to the drug-induced tab. That's the machine learning of VisualDx kicking in and really showing you if there's any citations of clindamycin linking to abdominal pain. Or any other diagnoses. So in the lower right corner here, we actually link the publication through PubMed. That's our medical librarians citing that. And if you wanted to go into the drug-induced abdominal pain article, we can view the drug reaction data and also look at potentially other medications which could be contributing to this. So with that, I'm not sure if there's any questions that came in. Looks like there isn't, but if you do want to set up a meeting, happy to discuss special pricing for residency programs, private practices, healthcare systems. We're integrated into EHR, both Epic and Cerner, and as Kim mentioned, we're in over 2,300 hospitals and large clinics. We do appreciate the time and certainly look forward to future webinars with VisualDx. Thanks so much, Kim.
Thank you, Mike, and thanks again to Dr. Chris Bunick from Yale and to Mike Venanzi and to Almiral. Hope everyone has a wonderful evening. And again, this has been recorded, and we will be sending that out to everyone who registered for tonight. Thanks again, and have a great evening.